Yes, please. Good evening, sir.
Good evening.
Greetings. Should I
Good
start,
evening.
sir?
Yes, please.
Yeah.
Yes, please. Yes.
Greetings and a warm welcome to all the dignitaries present here. I'm Sreyoshi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the Indian College of Anesthesiologists, and the focus of today's session is Frontiers in Obesity Anesthesia. So let's begin today's session, for which I'd like to invite Dr. Manjula Sarkar ma'am to take over. Over to you, Manjula ma'am. You may proceed now.
Thank you, Sreshi, for kind introduction of the day, topic, and mine. On behalf of Indian College of Anesthesia, I welcome you all for today's program, academic program, which is going to be on the frontiers in obesity anesthesia from physiology to policy making. Regarding ICA is concerned, ICA is conducting lots of academic activities, conducting webinars on every Wednesday, and we are choosing the topic in such a manner that they are going to be beneficial to our students, our faculties, and private practitioners too. So there is one new news which I would like to share with you all, that recently we have done one collaboration and association with American Society of Anesthesia, and this is going to be advantageous to all our students. They are offering 1-year membership for students in the concessional price, $31. And you can take the membership and you can take the part in all the academic activities which they are going to conduct during year 26. So that is the new achievement, and I'm really happy that our students are going to get benefited out of this collaboration and association. So without delay, I would like to hand over the mic to our moderator, today's moderator, Dr. Prerna Soni, and Dr. Prerna Sinha, and she is Principal Director of Max Institute of Laparoscopy,
Dr.
Endoscopy.
Aparna.
Aparna Sinha, Manjula.
Achha, Dr. Aparna Sinha. I'm so sorry. I apologize for the wrong spell. And she's Max Institute of. She's a Principal Director of Max Institute of Laparoscopy, Endoscopy, Bariatric, and Robotic Surgery, Max Super Specialty Hospital, Saket, New Delhi. And her area of interest is anesthesia for patients with obesity. Obesity is a real problem in this era, and so many patients are coming with obesity. And her interest is in research RCTs on opioid-free anesthesia, TIVA versus inhalational techniques, perioperative GLP-1 RA care, inhalational techniques, education, faculty, national and international webinars, workshops, and panel discussions. Quality and safety, JCI compliant audits and implementations of enhanced safety protocols. Academic contributors, authors of Redefining Safety in BAR. Many publications, many awards on her credit. So without further delay, I would like to hand over the mic to Aparna Sinha for further proceedings. I welcome Dr. Aparna ma'am.
Good evening, everyone. It's an absolute delight to be a part of ISA's academic activity, and we have learned so much on the ICA platforms and all academic endeavors taken by Indian College of Anesthesiologists since last so many years. So we always look forward to the academic events organized by ICA. So today, it's an absolute delight to be, talking on taking up such an important, burning topic, that is affecting not just the perioperative care, not just anesthesiologists, the surgeons, endocrinologists, the patients, their safety, and all the protocols alike. So without delaying, let me dive into it. Just give me a moment. So before I proceed, Vineet, I think Dr. Nagendra is having some problem in logging in. If you could just help him, because he's
Sir,
an
it's
important.
showing just now.
Hello,
Yeah,
can you hear me?
yeah,
Yes, sir.
Nagendra is there. Yeah. So let me just start. Yes, Nagendra, we can hear you. And just a couple of seconds before you joined, we have just started. This is the first thing. And we had an introduction by the Indian College of Anesthesiologists.
Yes,
And
yeah.
this is the presentation. So an important topic, frontiers in obesity anesthesia from physiology to policy. So this is an ICA endorsed online symposium where we hope to, discuss the current controversies and innovations. So I would be moderating this session, and let me first introduce my panelists, Dr. Nagendra, who is joining us from Royal Derby Hospital. He's consultant anesthesiologist, and he has extreme interest in upper GI surgery, peri-op stratification, and regional anesthesia. And I'm sure all of us are going to learn immensely from his talk and his discussions. Then we have Dr. Vandana Soni, who is a surgeon par excellence, and we all are familiar with her, and she is recognized internationally as Surgeon of Excellence for Bariatric and Minimal Access Surgery by Surgical Review Corporation. And she has immense contribution in perioperative care and surgery of patients with obesity, along with other patients. So definitely, we look forward to getting inputs from her in the panel. Then we have Dr. Dinesh Punhani. He's Senior Director at Max Institute of Laparoscopy, Endoscopy, and Bariatric Surgery at Max Arcade. He has extreme interest in patients with obesity, in anesthesia for patients with obesity, and is involved in departments, all academic activities, and hospital administrative activities as well. We have Dr. Anil Sharma, who's Senior Consultant Anesthesiologist from Apollo Hospital. Very enthusiastic, very high energy levels Anil has. And his areas of interest remain bariatric anesthesia, anesthesia for robotic surgeries, organ transplantation, and onco-anesthesia. We have Dr. Anu Vijayant Goel, who is Director Anesthesia at Fortis Shalimar Bagh Hospital. And
Okay.
his interests are also wide, ranging from labor analgesia, joint replacement, renal transplant. And he is also very active in the ISA's activities. We have Dr. Sangeeta Patro, who is consultant anesthesiologist at Max Institute of Laparoscopy, Endoscopy, and Bariatric Surgery at Max Arcade. And her areas of interest remain patients with obesity and regional anesthesia. So let me come back to the topic of frontiers in obesity anesthesia from physiology to policy. So let me just quickly take you through what we are going to discuss today. We are going to talk briefly about GLP-1 agonists, flozins, and how they are affecting the perioperative environment, how they are affecting the anesthesia outcomes and surgical outcomes. Then we will like to, touch upon some medico-legal flashpoints. So we all are aware that in last 2 decades, bariatric surgery picked up, and so I think the mic needs to be muted for somebody. Yeah,
Yes.
so we all are aware that in last 2 decades, bariatric surgery increased by leaps and bounds, and it redefined our clinical pathways and skills for weight loss surgery. However, what happened in last 10 years is that we started having obese patients, not just for bariatric surgery, but non-bariatric surgeries also. Posted for day case surgeries as well. Most importantly, it was observed that they are more and more metabolically volatile, and they have conditions that impact cardiovascular, respiratory, and the recovery outcomes in the perioperative environment. So what we are going to discuss is that it is not just about what is hiding behind a BMI value. We want to find out what's happening deep down inside the patient. What is happening? What else? What are the other things that are affecting the patient, that is happening with the patient, that is going to affect our outcome, and we would like to call it as the invisible burden. So, what is this invisible burden that we are talking about? There's widespread use of GLP-1 receptor agonists as well as fosins that are altering the gastric emptying and fasting physiology. So these agents, they act on glucose they act on the glucose GLP-1 receptors in the intestinal mucosa. They increase the secretion of insulin and suppress the secretion of glucagon. So they alter the glucagon insulin ratio. Moreover, they also have effect on the cardiovascular and metabolic benefits through weight loss and improved endothelial function. So our interest here is mostly on their effect on delayed in gastric empty, secondary cardiovascular and metabolic benefits through endothelial improvement of this function. So why is this topic important and critical now? We all are aware that there is exponential rise in GLP-1 receptor agonist use for diabetes and weight loss management. And we are increasingly aware that they delay gastric emptying, they increase the residual gastric content despite following the ASA standard protocols. So of late, what has been observed world over in last 5 years is that there are immense case reports that have triggered major guideline updates between 23 and 2025. So in the phase 1, which was a silent rise of use of these agents, was between 2018 and 2021. So what was observed was that GLP-1 receptor agonists were increasingly prescribed, not just for diabetes, but for weight loss reduction as well. Although anesthesiologists were aware that they affect the gastric emptying, but the fact that they are affecting our fasting protocols was not in the limelight. And we could not link it to aspiration risk in the theater. In the phase 2, which started in 2022 and lasted till 2023, case reports started pouring in where there were reports of regurgitation and possible aspiration, which were attributed to perioperative use of GLP-1 receptor agonists. So the first such case report was published in the journal by Anesthesia for Patient Safety Foundation, where they talked about patients, who in the perioperative period, despite following the safety standard protocols, were suspected of having regurgitation and possible aspiration. This raised alarm bells across the anesthesia community, concerns spread across anesthesia and endoscopy communities as well. And this was taken to be as a very serious outcome that was affecting the anesthesia outcome. So in the phase 3, the ASA task force responded by June 2023, where they released ASA interim consensus guidance on an urgent basis, where they brought it to the notice of anesthesia community, the growing patient safety concern because of perioperative use of GLP-1 receptor agonists. So thereafter, many societies, including Anesthesia Society of Anesthesiologists, Metabolic and Bariatric Surgery, International Society of Perioperative Care of Obese Patients, SAGES, and many more societies which came together to formulate the guidelines. So I will end my part here and first hand over to Dr. Nagendra to first, take us through what he has to tell us about another group of agents, that is the flozins. And after that, we will have a brief case scenario, and thereafter we will begin our panel discussion. Dr. Nagendra, can I invite you to please present your points about the flozins?
Yes, thank you, Dr. Aparna Sinha. Thank you for the invite.
Yeah.
And I'm extremely honored to be part of the panelists. Can you hear me, please?
Yes, we can hear you.
Okay, right. Okay, this, as you rightly said, Dr. Sinha, the group of drugs which has significantly affected the anesthetic practice in the recent months are these two group of drugs. One are the GLT inhibitors and the SGLT2 inhibitors. The main indications for these drugs were for weight loss reductions and their flozins for control of the diabetes in particular, and the other indications, I'll come to that later. But the implications it had for the anesthesia management was quite significant. Coming to fluozins, as we are all aware, there are four new drugs which have been here around for the last around 15 to 17 years when they became quite widely used. Um, so the four drugs, I'll just start with the four drugs. They are the empagliflozin, usually prescribed as 10 milligrams, dapagliflozin 5 to 10 milligrams, canagliflozin 100 milligrams, and ertugliflozin, which is it comes in 5 milligrams. Now, the commonest drugs used across Asia, UK, and the Americas is the empagliflozin and dapagliflozin. Canagliflozin and ertugliflozin are also prescribed and used in Canada and in North America in particular. But the commonly used drugs are empagliflozin and dapagliflozin. And just a few um, uh, points on where these drugs act. These drugs act on the proximal tubule, just which is going back to the anatomy just after the glomerulus, and where the 90% of the reabsorption of the glucose occurs. Now, if this channel is blocked, inhibited, then because of the glucose not being absorbed and because of its association with the sodium co-channel transporter, even the sodium is also taken away with it along with lots of fluid. And that itself is a significant advantage in how these drugs work. So there it prevents the reabsorption of glucose back into the bloodstream, and so it decreases the blood sugar levels and causing more control, giving us more control over the glucose homeostasis. And because it acts on the sodium channels, even the sodium is also is reduced, causing natriuresis. And because of this, you have a control over the blood pressure. So because of these two, you already have a good control over blood glucose levels, and also reduces the blood pressure because of its action on the sodium co-transport channel. And because these two are significantly impacted with your ATP levels, this particular channel, the SGLT2 co-transport channel, it gives you significant renal protection in terms of your oxygen expenditure in this particular structure, which is the proximal tubule. And because of the above two levels, which is the reduction in the blood pressure and the reduction in your blood glucose levels, you have an indirect, or we could also say a direct cardiovascular and renal protection. And because there is a significant loss in fluid as well, along with a good control of your blood glucose, it also leads to significant weight loss. And so, this leads us to the indications for the use of these drugs. So, initially, what started as for a purely diabetes, particularly type 2 diabetes, mellitus management, because of its action on this natriuresis and because of its action on management of your fluid imbalance as well, it's been significantly used in heart failure conditions. And because it gives a significant renal protection, it's also used in chronic kidney disease stage 2 and stage 3 in particular, with or without diabetes mellitus. And so these drugs has become significantly important in the perioperative use of the either elective and emergency surgeries. Thank you.
All right. So let me, Dr. Sangeeta.
Yes, ma'am. Yes,
Yeah.
ma'am.
So I think please present the case scenario.
Hello, good. Thank you so much, ma'am. Good evening, everyone. So I am presenting here today a case, the 67-year-old gentleman with a BMI of 55 who presented to the hospital with features of acute cholecystitis. He was planned for a laparoscopic cholecystectomy. On evaluation, we found that he had undergone a gastric bypass surgery around 12 years back. Hello.
Yeah, yes, go ahead.
12 years back, when he has reduced around 76 kilograms. But of late, like in the last 6 months, he was regaining weight, for which he was under medical management. He was taking injection Monjaro 3 mg weekly once, and also is on tablet dapagliflozin 10 mg. He is a hypertensive, he's on beta blockers, and he gives a history of a recent hospital admission wherein he is diagnosed as a patient of congestive cardiac failure with features of dilated cardiomyopathy, gives history of low myocardial function with a EF of 30 to 35%. His medications history show that he is taking Vimada 100 mg BD, tablet Ditor 10 mg OD, and also on he's on metoprolol 50 mg, and on evaluation we found that the patient is having is conscious and comfortable. His vitals were stable. Most of his investigations were within normal range, and his cardiac evaluation as of now showed that he is having a good myocardial function of a EF of 50 to 55%. I will hand over to Dr. Aparna for further proceeding.
Okay, thank you. Thank you. So let me begin the panel. First, a few questions we'll run through for the GLP-1s. Dr. Anil, have you seen that there's a surge in prescriptions for the GLP-1 agonists and the flozins in your practice? How is it? I mean, how do you approach a patient with obesity with respect to these medications? What is your experience?
Patients are very forthcoming that they are on these drugs, and in RPAC clinics, you have to proactively ask whether they are taking something like that. So, and definitely now the numbers are increasing. Of late, like though it's the prevalence is less, like maybe 2 to 5 cases in a month we are encountering, and then when we searched the literature, and we told them about like how to go about it, like especially the young females, some patients on narcosis or bulimia, even they are taking just for the sake of reducing their weight, and unknowingly or being prescribed or just by hearsay on internet they have started. So this is a real big problem when you have to carefully elicit this history in this subset of population, and we are encountering regularly now these patients are there, ma'am.
All right. And what about you, Dr. Anu? How is your experience with the changing prescriptions for the patients who are coming to the pre-op clinic?
Good evening to all. First of all, I would like to thank Dr. Aparna for my eye-opening session. When she gave me this topic 15-20 days back, I am almost, we are in a very light practice of going in PSC, oral hypoglycemics, stop. Cardiac medicine, continue. Blood thinners, yes. But when this topic was given to me and I started studying about this topic, I am not ashamed in telling there is so many increased incidence of these drugs. Patients are coming to clinics, but they are not indulging themselves. They are taking these medicines. After getting this topic, I started asking the patients, give me the prescription of medicines you are taking. And our cardiologists these days are very fond of using fluonosins. So in last 1 month, I could find 5 to 6 prescriptions which were taken by the patients with fluonosins and GLP-1. So I would like to thank Dr. Panda, and I took the special class of my DNB students, those maximum PSCs, just to ask these questions particularly, and in the evening tell me how much patients were taking these medicines. Yes, incidence is increasing. Incidence was earlier also, but I would like to say we as anesthetists are not aware of these things, so we are not asking the leading questions. We should ask more and more leading questions about these drugs.
Right, absolutely. I I really appreciate what you are saying. So, Dr. Anil, would you like to take us through the guidelines? What do the guidelines say? I mean, how should we approach a patient, let's say, who's on GLP-1 agonists? the ASA guidelines regarding discontinuation of
Actually, ma'am,
the
I just want, yeah. So, 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 a very big coincidence that I would like to highlight here. You believe that when the ASA first came with the guidelines 2023, they just blindly said once a day dose you stop a day before, and then once a week you stop 1 week before. But then on further research, exactly today, that is October 29, 2024. Okay, will you believe it today that we are discussing exactly 1 year before they brought this new multi-society clinical practice guidelines, and wherein, like as you mentioned, the ASA, American Gastroenterology Association, then
yes,
Metabolic and
SAGES,
Bariatric Surgery, they came, SAGES
SAGES,
and
yeah,
all, they came together, right? So
yeah.
you know what is 1 in 8 patients in US is on Ozempic. Such is the magnitude of the issues, basically. So they came up with a few guidelines wherein they were very clear now that 4 main points are there, that whether the patient is in escalation phase of the treatment on Ozempic. So if
Right.
the patient is taking Ozempic less than 12 weeks duration, or if the dose is getting increased, then the elective surgery should be deferred. There is no
Okay.
ambiguity on that part of it. Now, again, the patients with active GI symptoms who are facing certain side effects of these drugs, like nausea, vomiting, pain, etc., let them settle. So, if that phase is there with the patient, please don't proceed with an elective surgery. Then, if higher dose is there, then better to follow liquid diet for the 24 hours. That is very clear. So don't postpone the surgery, but take this precaution that the patient should be on a liquid diet pre-op for the 24 hours. And then the fourth condition, then they decided whether there are other medical comorbidities which cause gastroparesis, like patient of Parkinsonism, long-standing diabetes. Then you have to modify their peri-op management plan, wherein you have to keep them fasting and then go ahead with the elective surgery. So this is what they modified in October 2024. So the main crux was that liquid only diet when you recognize that you have to go ahead with the surgery and the patient is on drugs. So only liquid diet 24 hours before. This protects the patient from risk of aspiration. So this is the
All
ASA
right.
guideline.
Okay, okay. So let me move to Dr. Dinesh. Dr. Dinesh, when you have some such patient, who you have instructed that they should, let us say, discontinue their medication for a week, and patient reports to you for admission, and the patient is still continuing. So how will you approach? I mean, what is your take on such a patient? Patient hasn't followed your instruction. You're on mute.
So my question for me was, if patient on GLP-1 has not
Yeah.
adhered to the recommended
Not
period.
adhered to your instructions and is still
Yeah.
continuing to
Okay.
take.
So I will divide my answer into two parts.
Okay.
Although Dr. Anil has already explained about the elective surgery and all that.
Yes.
If it is an emergency surgery, we should consider these patients as full stomach, because there is delayed gastric emptying. And we should take all the measures which we normally do while giving anesthesia to the patient with full stomach, like rapid sequence induction, giving preference to the regional anesthesia, head up, use of prokinetic drugs, etc. Now, in addition, we can do ultrasound to check the gastric volume and contents to substantiate it.
So that means you will accept the patient when the patient has
Yes,
come
for
to
emergency,
you.
they have to accept.
And what about emergency?
Elective.
Sorry, what about elective surgery?
If it
Yeah.
is an elective surgery, we must dig into the proper history, whether these drugs are recently started. By recent means duration of therapy is less than 12 weeks. Or as Dr. Anil said, if patient is in escalation phase, that means their physician is increasing the dose. Or if patient is experiencing symptoms like nausea, vomiting, bloating, abdominal distension. So in that case, we must discuss the potential risk of regurgitation and aspiration with patient and as well as with surgeon, and postpone it. And if patient is not experiencing these symptoms or the duration of treatment is less than more than 12 weeks, we must proceed with caution. So as Dr.
Yeah.
Anand said, give liquid diets for 24 hours. Of course, fasting period will be the same. Then you can add prokinetic drug in that period. And again, you can check with the ultrasound before the surgery to check the gastric volume to substantiate it.
Yeah. So what has happened? What we are seeing in literature is that, these guidelines and following them blindly has led to an indiscriminate number of cancellations of elective surgeries. And so I want to know from Dr. Vandana, what is her take on it? And when we have a patient, who the anesthetist informs you that has not followed the instructions to the T, like instead of 7 days, maybe they have taken it for 5 days. So what do you think how we should proceed? What is your say on this?
First of all, thank you, Aparna, for having me here. I think so far a lot of very interesting discussion going on. And yes, GLP-1 are a class of drugs. Flozins, I would say that I am not very familiar because those are drugs which are primarily used by physicians. But for GLP-1 analogs, receptor analogs, these are drugs that we have been using quite commonly. The usage has escalated, and a lot of patients are taking these. I mean, patient may not come necessarily for a bariatric procedure, it can be for any procedure, but the patient is already taking these medications. So, of course, apart from finding out whether the patient is taking or not, the patient has post surgery has been advised to discontinue and does not discontinue. There are certain clinical scenarios where you will have to balance out, instead of, like you said, indiscriminately canceling, to be judicious about who are the patients who can be safely postponed and who are the ones where you need to give some, you can say, on certain
Leverage.
grounds you allow, that leverage. For example, the patient is traveling from outstation. There are economic issues which are there. The patient, may be having a problem getting an insurance. They finally got it, and cancellation may result in problems later. So in all those scenarios where, it's not the medical condition, but the social issues which kind of push your hand towards it, I think that time it is important to coordinate with your anesthesiologist and plan the surgery in a manner which turns out to be the safest and most feasible for the patient. So for that preparing, I think it has already been mentioned, but if possible, to keep the patient on oral on an oral liquid diet. There is this a recommendation by the Australian and New Zealand Association
ANZA,
ANZA, for managing obesity, in which they say that certain prokinetics like erythromycin, they have actually
injectable erythromycin,
just prior to the procedure actually expedites the, in fact, it is effective even in patients of gastroparesis, vis-a-vis the other prokinetic agents. So a patient who had gastroparesis was given prokinetics like Perinom and Cisa or Ganton, did not show the same response as was seen with erythromycin. So although this has been studied in situations where, it is a patient coming for an upper GI endoscopy, I think it is a drug which can probably be used even pre-operatively.
Yes, I agree. So that was a very valuable input. And in fact, I was also digging into literature. And what I found was that, because evidence is still building up, evidence is still collecting, and we still don't have, any systematic study or an RCT, to substantiate whatever suggestions or guidelines are there. So I was going through the literature, and what I found was also that there are some case reports by Anesthesia Patient Safety Foundation is one of them, where they found that the certain medication was discontinued for double the time of what is recommended. there were no symptoms. Patient was not having symptoms of fullness. Patient was not nauseous. Patient was not having any comorbid conditions. Still, the patient, had evidence of regurgitation, but thankfully the endotracheal tube was in situ, and they could only aspirate through the Riles tube the food content that the patient later said was taken a couple of days back. So it is not like if we have, sort of allowed that many days to pass, then we are in absolutely safe zone. So when the patient is on table, that time again, probably we must reassess, the patient. And as you said that in some patients, we have to give leverage, take certain precautions. And if it is not in a very high risk zone, then maybe go ahead with adequate precautions and, take up the patient maybe. So with that, I think I will move ahead with Dr. Nagendra and see what is happening in the United Kingdom, how they are handling patients like this, and what are your inputs, Dr. Nagendra? We are very eager to know.
Yeah, with respect to these weight loss medications, initially when these drugs came into the day-to-day practice, especially the anesthetic perioperative care, there was a lot of confusion as around the world. What happened was initially we were told that we need to stop for 28 days, then it became 7 days, and then it said depending on the urgency of the case or depending on the nature of the surgery. So now with the ASA guidelines and the local NICE guidelines, so what has been decided is that it all depends on the nature of the surgery and the urgency of the surgery, and also with respect to the how fit the patient is with respect to undergoing that particular of surgery. So what I'm trying to say is that, say we do not have a blanket 7 days, which is the minimum period required for these weight loss reduction surgeries to go ahead. With the advent of POCUS, and especially with the advent of our very advanced video laryngoscopes, we could manage any of these patients coming with, even if they've taken for 2-3 days before coming to surgery, for example, cancer surgery requiring a colorectal or upper GI surgery, even if they've taken this particular drug, or any emergency surgery or urgent surgery. So now if there are two scenarios we are regularly encountered with. Suppose if they have taken a drug which is on an escalating dose, and if they usually these drugs are taken weekly or at least fortnightly. If scenario A, if these drugs are to be taken in the coming week, we tell them do not take it till they have the surgery. Say, for example, the surgery is in the coming week, and if they were supposed to take on coming Sunday, we tell them not to take it. And if they have taken the surgery, if they've taken the drug on Sunday, and if the surgery is on, say, Tuesday or Wednesday, and we tell them that to be on liquid diet for those 2-3 days, at least for 24 hours before surgery, and proceed with the surgery. As I said, the advent of the video laryngoscopes and with the use of our techniques for modified rapid sequence has greatly and immensely helped us in canceling these patients on if these people are on drugs. And I think throughout the UK, this is what is being practiced. We do not necessarily cancel them blanket unless they have taken the day before surgery and they are still on a solid diet. And if they're still on that, if it's emergency surgery, it's a different scenario. But for elective surgeries, this is what we practice. And yes,
Yeah,
obviously, sorry, a word on POCUS. Not many of us, or there are I shouldn't be saying that, a very few of the anesthesiologists are very well versed and confident in doing POCUS, and there are not much facilities to do POCUS. So relying on POCUS for gastric emptying and gastric ultrasound is also not that conducive, and leading to delaying the list. So we just carry on provided these conditions are met. Hope
yeah,
that was clear.
so one thing that Dr. Nagendra, I would like to ask you also, what, if a patient is being taken for, let us say, an MRI or an endoscopy or if a patient is for regional anesthesia, for example, it's a joint replacement, and the patient is on GLP-1 agonist, what special techniques you would use, or how would you modify if a patient you have planned to give regional anesthesia, for example?
Right. Okay. So yeah, I think let me take you in the different scenarios you've expressed. So if it is for regional anesthesia, if the patient is coming for an ankle surgery or a knee surgery, and if the patient has taken on, let's say patient the last Sunday, the Sunday which has just gone, and the patient is going to have surgery on this Wednesday or day of tomorrow, we would just carry on. We would not delay the surgery. We would, because, and if we are going to do it under spinal or epidural or combined spinal epidural, we would carry on. Now, this is for a surgery where the patient has to be supine. Now, if there is any change in the position of the patient, for example, for hip surgery, coming for hip revision hip or complex hip surgery, then it becomes a bit of a challenge, because if the patient has taken this drugs on the medications, I mean, on the say of preceding 48 hours, and if the patient is continued to be on solid diet for those 48 hours, we would delay it for at least another 24 to 48 hours to the patient to be taking only liquid diet, and then we would continue. So this is for regional anesthesia. And for endoscopies, we are strictly told, we have been issued guidelines that because the endoscopic units are not there as part of the big regional theater theater regions, and because they are usually on another site, we do not encourage these patients to be done on a faraway site. So even if it is for endoscopy, either for a gastroscopy or colonoscopy, we are encouraging them to be done in proper general theaters. And the recommended guidelines is to have a definitive airway, irrespective of whether these patients are on solid diet or liquid diet. So we are encouraging these patients to be intubated and be dealt as with any other general surgery. And if these patients are in MRI, then again, depending, because these patients are going to be depends on the indication for MRI. We are, if it is for a peripheral, say for example, a peripheral MRI for a peripheral structure, say ankle or a knee, then it's okay. But if it is for an MRI for an abdominal structure or a thoracic structure, where this amount of time is significantly going to be higher, if the patient has taken very recently, that is less than 48 hours, then, and if the MRI is inevitable, then we ask them, we are encouraging, the guidelines are to intubate the patient. Thank you.
Right. Yeah. And any choice of agent for regional anesthesia? I mean, let's say it's a long surgery. So would your choice of anesthetic agent also affect in a regional anesthesia? I mean, what if
Yes.
the
So
surgery is
what we are
extended
saying
beyond?
is that because of this potential of you using, obviously you need to know your surgeon and you need to know what the surgery entails.
Yeah.
Suppose if the surgery is, and if you are not sure about it, we are asking our colleagues and our students to use a longer acting spinal anesthesia. So even if it is, even if it outlasts the surgery for a significant time, and even if it significantly affects the patient mobility and physiotherapy, I think it could be traded off with the safety we are going to get, rather than not putting the patient to sleep midway. So we are using longer acting, even like 0.5% plain bupivacaine instead of heavy bupivacaine, along with the peripheral blocks. And that's been our guidelines and recommendations for all our colleagues and students. Yes, so for these procedures, that's a very good question, Dr. Sinha. So using a longer acting spinals is what we are recommending.
Yeah, thank you so much for your inputs. I think Dr. Vijayant, were you asking something? Anil was asking.
Yeah. So, ma'am, a very interesting thing, like since you were talking about the THRs and TKRs. So, in March 2025, in the annual meeting of American Academy of Orthopedicians, can you believe they presented a study and the study was titled Optimal Timing for Cessation of GLP Agonists Before Elective THR and TKRs. So even they got concerned because the study found out, basically it compared the patients who had cessation of Ozempic, basically 30 days prior, 14 days prior, 7 days prior, 5 days prior, 3 days. This is the cohorts they divided, and 170 patients didn't stop Ozempic prior to the surgery. So what were their findings? They found out that those who were like where the stoppage was just 3 to 7 days, they were at increased risk of aspiration, increased risk of aspiration pneumonitis. They required intubation. If they required intubation, then there was a problem, and there was a delayed emergence from anesthesia if the cessation was less than 7 days. So I just
Right.
wanted to add to this thing that even
Thank
the
you.
surgeons found out in this comprehensive study, and even they were concerned with the
Yes.
continuation of the GLP-1
Of course,
agonist.
of course.
Thank you.
Yeah, of course, of course. So one more thing is that when we are discontinuing, because we know these agents are being increasingly used not just for weight loss and diabetes, but also for, let's say, non-alcoholic liver disease, because of increasing metabolic derangements, even NAFLD, even PCOD. So when we are discontinuing, or we have to make sure that we add some bridging. For example, if the patient's, GLP-1 is for diabetes, then we must instruct that they should monitor their blood sugar. And if there are hyperglycemic episodes, then that needs to be managed as well. I mean, it should not be like a blanket stop. The communication has to be very comprehensive and extensive. So that includes a sort of medical legal flashpoint also, that when we are giving instruction to discontinue, then we must tell them the advantage and how they have to be bailed out of that situation in case there's, and what all they need to be monitored, and when they should restart the medication, right? Yeah, I think Dr. Anu, were you saying something? Or we can move to the next set of questions.
Yes, ma'am, we can move, yes.
Yeah, so let's move to the next set of questions that will be about the flozins. So for the flozins, I'll first start with Dr. Anu only. So how are you finding that in your practice things have changed? And, with respect to use of flozins in the pre-op, and how often do you sort of dig into the history and instruct that they should stop the flozins, and how do you sort of manage if the patient has not discontinued flozins in the preoperative period?
Ma'am, these days we are not getting much of patients for bariatric surgery in our hospital. We are getting few cases, but most of them on GLP-1 and 2. We are getting cases for non-bariatric surgeries, which are in which cardiologists have advised SGLT2 inhibitors them for low EF or for congestive heart failure. In that cases, in that patients, the patient is coming for emergency surgeries. We cannot say no. We are proceeding with the case and keep very high suspicion of euglycemic diabetic ketoacidosis, which we miss. And if we are getting the elective case done, even if we, as per guidelines, we have stopped 2 to 3 days, 3 to 4 days earlier. In that case, also in post-operative period, we keep very high suspicion of euglycemic diabetic ketoacidosis. Even to the surgeon, we instruct if the patient is complaining of fatigue, lethargy, tachycardia, don't confuse with the symptoms of the surgical complications. Just keep in the mind normal glucose in the different situation. In this cases, glucose levels will be normal, and we have to give the very high suspicion of ketoacidosis, and we should straight go away, get the ABG or venous blood gas done to confirm the diagnosis.
Yes. Yeah, that is sure. Dr. Nagendra is around. Is it got disconnected? I'm not sure. Yeah. So Dr. Nagendra, I would like to ask you, how these patients should be monitored in the preoperative period. If a patient who has not sort of discontinued the medication in the pre-op, what should be our take in the pre-op period? Let us say they have not discontinued for the required, let us say for 3 days, and they have reported for admission, then how should we proceed? Dr. Nagendra, are we audible? Dr. Nagendra is there, logged in.
I think his connection is lost.
Never mind. Dr. Dinesh, would you like to answer this? That if a patient has not discontinued their Flozin for the required period and has reported for admission. You are on mute.
Yeah, so in that
Yes.
case, we must first inform the patient about the risk of euglycemic diabetic ketoacidosis.
Yeah.
And the return information and management plan should be discussed with the patient. That we need to,
Right.
send samples for ketones and sugars, and we must explain this to the patient. And depending on the surgery, whether it is a major surgery or minor surgery, or if we are expecting early resumption of the normal diet, in that case, our management depends on that. So if it is a daycare surgery or a short surgery in which we can resume the normal diet, we normally we send the sample for the blood ketones. But in post-operatively, there is no need if patient is resuming the normal diet. But for major surgeries, for bowel surgeries, in which we are anticipating that there will be prolonged fasting period. So pre-operatively, we send the sample for ketones. Post-operative, if the duration of surgery is more, then every hour we send ketone samples.
Yeah. So at sort of what level would you sort of accept the patient for a surgery, and when will you say that no, this patient should be deferred and we should, sort of optimize?
So it depends on the ketones levels. Like if it is more than 1 millimole per liter, with or without hyperglycemia, or if there is low base excess, less than 5 millimole per liter, in that case, we should defer.
Yes, absolutely. So we should correct the acidosis if possible, and we should maybe keep the patient on hydration. We can maybe monitor the patient again in the, have the patient admitted, especially like we were discussing that a lot of patients are coming from far off or have got the slot in some countries. It's difficult to get a slot for surgery. So we cannot really cancel. So in those patients, they can be admitted and we can start hydrating, start correcting their sugar and acidosis and monitor the ketone levels maybe every hour to begin with. And once it shows a downward trend, then every 3 to 4 hours. And once it is in normal range, which usually happens in a day's time, in that case, we can take the patient once the correction has been met. But if the patient is a purely elective surgery and there is no such issue, and if the ketone levels in the capillary are more than 1.5 millimoles per liter, then that patient should definitely be deferred, prepared, and then readmitted. So I think that is one thing that we must follow. Dr. Anu, I would want to know from you, like, let us say if a patient is for bariatric surgery, or if a patient is for GI surgery, or if a patient is for, let us say, for a gallbladder surgery, then with respect to the SGLT2, are there any difference in your protocol and in your management of that patient?
Yes, ma'am. The point which I wanted to edit, because SGLT2 these days are mostly prescribed for cardiac conditions, patient with low EF and CHF. In that case, it has been shown that if we stop the drug for 3 to 4 hours, 3 to 4 days prior to surgery, it has adverse effects. In that case, if the patient is not for bariatric surgery, the patient is taking this drug for clear-cut cardiac indications, we need not to stop the medicine in a preoperative period.
Absolutely.
We should keep the very high suspicion of diabetic ketoacidosis. We should keep our antenna up, and we should see each and every symptoms we should discuss with the patient. We should discuss with the perioperative team. These symptoms can be alarming for diabetic ketoacidosis. We should get the ABGs done. But if the same patient is coming for bariatric surgeries, it's a totally different scenario, because in bariatric patient is fasting, dehydrated, surgical stress is there, and even in post-operative period, patient will be carbohydrate starved. He's not going to take the much amount. Even we start
Absolutely.
early,
Yes.
the intake will be very, very less. So the ketogenesis
Yes.
will be very more because of starvation and because of these drugs. In that case, we need to stop 3 to 4 days earlier, and even in
Yes.
post-operative period, we should not hurry to restart these drugs because
Yeah, that is
carbohydrate intake will be very less, man.
yes, that is absolutely true that, patients, when they're coming for bariatric surgery, quite a few of them have been kept on very low calorie diet.
Yes.
Quite a few times they're kept on diuretics pre-operatively to put them in a optimized situation. So that patient, if that patient is taking SGLT2, then probably we have to stop them much earlier.
Yes, ma'am.
We have to stop the SGLT2 much earlier. And those patients have to be monitored very closely after surgery for any evidence of acidosis. So sometimes, if surgery is prolonged and we do ABG and we see that there is an acidotic picture, and a lot of times we blame it on the fluids or duration without knowing that patient might be on an SGLT2 and we are not aware or the history was not disclosed. So that angle also should be kept. And one more thing is that, if a patient is taking, as you rightly said, is taking the SGLT2 for heart failure and we decide to discontinue, then that patient has to be really alerted to be monitored by a cardiologist or should watch out for the symptoms. And in many centers, they tell the patient to monitor their NT-proBNP in that period so that we know that the patient is not slipping back into a failure situation. Because for whatever reasons, like a patient with cardiac failure is for colorectal surgery. So it's like a double-edged sword. We don't know whether we should stop it or we should continue it. So for heart failure, you have to continue it, but from colorectal point of view, you have to stop it. So if you stop it, then the patient should definitely be under cover of a cardiologist who can monitor the cardiac functions and add some more medications in that period. So just like we discontinue blood thinners and we put the patient on a bridging, similarly, when we are stopping the GLP-1s or we are stopping the SGLT2s, we have to keep that patient on observation. So I have Dr. Nagendra back for his input. So Dr. Nagendra, yeah, we missed out your inputs. If you have a few minutes, I think you're on mute. You're on mute. Dr. Nagendra, you're on mute. How to convey it?
Dr. Nagendra, you're muted. You're muted.
Shresi, can you unmute Dr. Nagendra, sir?
Or maybe we can text on his phone or something.
Is it better now?
Yes, yes.
Yes, now we can hear you. So Dr. Nagendra, we have been really waiting to hear your inputs because you are the one who has expertise on SGLT2. Yeah.
Sorry.
So
Yeah.
So my question to you was, which we discussed amongst us, but maybe you will have, I'm sure, more inputs to give, that a patient has reported for, patient was on SGLT2 for heart failure also and for diabetes also, and has reported for surgery without stopping it. So how do we sort of check the levels? When do we decide, and how do we monitor this patient?
Okay, so the as I said, the indications has progressed from type 2 diabetes to heart failure and CKD stage 2, stage 3. Now, as we all know, the implications of diabetes is quite different from the implications of heart failure and CKD stage 2. And of all the three conditions, I think it's the heart failure with respect to the surgical stress, which has a significant amount of impact on the perioperative outcome of the patient. Of course, in addition with the diabetes. Now, given the scenario you have just elucidated, if the patient has not omitted the drugs on the day of the surgery, and if the patient was taking, and if the surgery has to be carried out, so what you do, you need to measure the blood ketones and the blood sugar levels. Now, there are different levels of ketones to be aware of. Up to 0.6, considered normal. 0.6 to 1, you need to observe. Above 1 millimoles of ketones, you need to start the treatment, which is your variable rate insulin. And above 1.5, you need to do a blood gas and look for anion gap. If the ketone levels are greater than 1, then start the variable rate insulin, delay the surgery till it comes to less than 1, and also do a blood gas if you have access to it. Now, if the blood gas, obviously, if the pH is acidotic and if the ketones is greater than 1.5, unless the surgery has to go ahead, like an urgent surgery or an emergency surgery, you have to delay or postpone the case. Now, if the patient, if it is less than 1, then you could still go ahead, minding the fact that this condition is not an untreatable condition. It can still be managed, it can still be salvaged, provided we have the facilities to do a bedside ketones and blood sugars. I'm sure all the hospitals throughout the world, especially in India, would have facilities, I think the major hospitals, to measure the blood ketones by blood side. So if the patient has not, the key take home message is, if the patient has not omitted the drug on the day of the surgery, that's fine. Do the ketones, do the blood sugar, look for the ketone levels, and if it is less than 1, you could carry on. 1 to 1.5, start insulin, delay the surgery. Greater than 1.5, do a blood gas, do an anion gap, and then probably have to delay the surgery depending on the urgency of the surgery.
Right. Mhm. So what will be your sort of takeaway about the flozins that you would like to tell the delegates who have all
So
logged in?
the key take home messages, I think, from our experience in the last 2 to 3 years has been this. Now, it is not an unmanageable condition. It can be managed. So delaying or postponing the surgery just because the patient has taken the flozins is, in my opinion, and also I'm sure you'd all agree, we're far-fetched considering the amount of time the surgeons, the patients, and the hospital care would have invested in him, unless it is too high risk. That apart. So if at all, if the patient is coming for an elective surgery, stop it for at least 48 hours. Now, I say 48 hours because there are guidelines from Americans, guidelines from Australia, which say stop it for 3 days. And this was, mind you, for patients who are only when they were prescribed for diabetes. Now, with the indications expanding to other severe life-threatening conditions like heart failure and CKD stage 3, particularly in the context of surgery, so we have to be a bit more pragmatic. So if the patients are on heart failure, even if they have stop it for at least 48 hours and then carry on with the surgery. Even if they have stopped it for 24 hours, I think depending on the risk and depending on the implications of the postponement of surgery, could still continue, provided you have the facilities to monitor the ketones and the sugar. And the other key take home is to note when to look for euglycemic ketosis, which is nausea, vomiting, small breathing, or a completely unresponsive blood pressure and an increased heart rate. I think if you do a blood gas, all these issues would be solved and would enhance in our decision making.
Yeah, and when, in your opinion, should the SGLT2s restarted at the end of the surgery?
So again, there are two kinds of scenarios.
I
now,
think,
for
yeah,
most of the
yeah.
orthopedic procedures, which can be done under real anesthesia, this is not an issue because the patients would be able to eat and drink probably in the next, after they're having the surgery, after 2 to 4 hours, which is a big advantage. The problem comes when these patients have had a general surgery, like a complex spine surgery or complex colorectal surgeries. Then we do not have any leeways there in those kind of situations. So, for example, if these patients have had GA and if they have had, they have to be nil by mouth for a considerable period of time, monitor glucose, monitor your ketones, And at the first instance of them taking orally, you can restart your flozins once they're taking oral intake is allowed, which is unlikely with major upper GI and colorectal surgeries. But for majority of the orthopedic surgeries, which is a big advantage, as soon as they eat and drink, you can start them on your flozins. And again, monitor your glucose. If the flozins are veering towards 1 or greater than 1, I would still continue the invariable rate insulin along with the glucose medications. I'm hitting a bit of a controversial aspect here, but I think maintaining that constant amount of insulin is the key to maintain to minimize the amount of ketosis, because the ketosis is due to the lack of insulin.
Yeah. So thank you so much. That was like really nice input, and I'm sure all of us have benefited from that. So the other thing we will just quickly touch upon some medico-legal aspects that we all face in our practice. And I will start from you because I know you have to start your case, and so what happens, when a patient refuses to follow a certain treatment or a certain protocol or certain technique or certain investigation preoperatively, or let us say refuses to take CPAP, refuses to do sleep study, or refuses to do a certain blood test. So how do we document that, and what should be the way forward, and how you deal with that medico legally? How do we protect ourselves in that scenario? What should be our approach towards the patient? Dr. Nagendra, are you there?
So mute, please mute.
For me? Sorry.
Yeah, that is for you.
Yeah.
Because
So,
I know
yeah.
you have to go. So whenever you have to go, you let us know.
Yeah, sure. So our stand has been in this case, particularly these kind of patients, is that especially when they come for elective surgeries, and if they are refusing, the scenarios we have met is patients, especially with the weight loss reduction drugs, the Manjaro and the other drug, where we have told them that if they are not complying with our guidelines, we have not proceeded with surgery, and we have to document, obviously, as with everybody else, and we are not carrying on. We are not going ahead with the surgery, and we do write the reasons for not going ahead, mainly because of the risks are too much to be taken compared with the benefits which the patients might think they are going to have. And that's been our stand, that if they're against the NICE guidelines, because we can't be protected medico legally by the trust or by your own indemnity. With respect to flozins, I think, again, because of the indications, if the patients are on, if they've taken the drugs for mainly for heart failure, and we have gone ahead, and then the patient has ended up in ketosis, and if there's been any complaints, as long as we provide the evidence, which has happened in the last 4 to 6 months, we have been able to successfully give the reasons so as to call in our defense, and as to why we went ahead. And we have, so far, there have been no instances of any controversies.
Okay. So Dr. Anil, would you like to sort of
Sorry, if I
enlighten us?
may leave now,
Yeah,
if you don't mind.
sure. No problem. No problem.
Thank you, everybody. Have a good day.
Yeah,
Thank you.
thank you. I know you have a case to start.
Thank you, sir.
Thank you
Thank
so
you.
much. Yeah, thanks a lot. Yeah.
So, ma'am, not only this, like, ours is a JCI accredited hospital, and we need informed refusal, if I would like to put it like that. And in informed refusal, basically, as we know, that patient has a right to refuse, in spite of the clinician telling him all the potential benefit as why he wants to carry out that particular intervention, and the risk benefit, and the alternatives available. So herein comes one important thing, whether the patient is decision capable, whether he has been informed, right, medico legally. So when we document this thing, we have to document certain important things like the patient information, like what was the patient's state at that particular point of time, right? Whether the patient understood, he was not intoxicated, he was not on any antipsychotic medications, he has the caregivers and attendants with him and all that, so that the liability, the medical legal liability release is there, right? Recently, I had there was this case in a corporate setup where this intestinal obstruction patient, he refused to get the rise tube put before induction of anesthesia, and I just wanted to tell the audience that what happened. The induction was done, patient vomited, aspirated, and could not be saved. Let me be very honest in telling this. So these are the consequences wherein now what happens. So luckily the surgeon has documented this and got it signed by the patient that this rise tube insertion is important in intestinal obstruction. And just because the patient has refused preoperatively, so any consequences, he is responsible. So the documentation of informed refusal is very important, and it has to be done in presence of witness. So now what happens if patient refuses to sign this informed refusal, right? So if that is the thing, then you document separately on the patient clinical care sheet that ex-patient has refused to sign informed refusal consent form, and this should be done in presence of two witnesses. So this is how medical legally where we stand. If the patient is not ready to go ahead, whatever we want to tell him or is in his interest, so there is in where if we document this informed refusal, then only we are our liability or medical legal liability is released on that particular case.
Yeah. So, Anu, will you like to say something?
Yes, ma'am. In corporate practice, as Dr. Nishima rightly said, there are so many cases where patient refuses for undergoing particular procedures. For example, if for an elective case DSC is positive and angiography is advised, sometimes patient says, no, I don't want angiography. And if angiography is done, angioplasty is advised, patient says, I don't want to go under angioplasty because there are medical treatment available also. In that case, in our hospital, what we do, we go for multidisciplinary team meetings in which doctor from cardiac side, operating surgeon, anesthesia, and from administration of the hospital side. There is one person, AMS, DMS, or MS present from the administration side, and attendants of the patients are present. Then it all meeting is video recorded and documentation is done by the administrative person present in the hospital, and that is signed by each and everyone present in that multidisciplinary team meeting. Patient is given option, you need angioplasty, yes, but patient says, no, I don't want angioplasty to be done, I would like to go for medical treatment, and I am willing to take the risk associated with this, and I want to proceed for the surgery on my patient, or patient says, I want to proceed for the surgery. We record this document, and we routinely do multidisciplinary team meetings for that. As far as phenologies and these drugs, new drugs are concerned, there is a very gray zone for that. There is, as
Yes.
Dr. Nagendra rightly said, there is a gray zone. There are no strict guidelines. There are no strict guidelines. But as far as our knowledge is concerned, we can document the things. Yes, patient has not taken SGLT2, but his ketone levels are normal, pH is normal, these things are normal. On that basis, we will proceed for the surgery, but
Yes.
by proper documentation.
Yes. Dr. Dinesh, I think you want to add something.
I just wanted to ask Dr. Anil, do they have any informed refusal form in their institution?
Sir, so right now that is what the debate is, that because we have this patient clinical care sheet, like where Dr. Anuvijan rightly said, where we document and we get it stamped and we get it xerox and we keep it in our records basically. So our quality team is working on this form, and I was talking to Aparna madam also, as and when it is finalized as per the JCI standards basically, because it has to be in compliance with the JCI audit basically. So our quality team is working on it, and I will definitely update on that. But right now we take it on the clinical care sheet of the patient, sir.
And do you do this video recording of this thing what Dr. Anu Vijay Goyal
No, sir, the video recording part is not done per se, but yes, in the front of the administration, patient's relative and this, like a multidisciplinary team meeting is held, and then it is decided that, okay, this patient has given a negative consent, and then he is responsible for the consequences of the same.
Right. So there must be some situations where we say that, no, we cannot operate on you. I mean, a patient is saying no but are there situations where we have refused surgery?
Yes, I think in this corporate world, now the surgeons are also tuned to this, that instead of going into the court liabilities and all that, if after counseling, first we try to understand like what is the reason. Is the reason financial? Is the reason out of its cultural or ethical things? Or is it because of his beliefs and all that? And after proper counseling, if he still insists and we feel that there is a definitive risk, then we politely tell him, okay, sorry, we will not go ahead with this. The surgeon who, because in a corporate setup, the surgeon and anesthetist has to be on board on the same page. So the surgeon also says, sorry, I don't want to take this much risk. There are ample patients with me. I will not go ahead with this if you don't comply with this. So we have
Yeah,
refused.
that is absolutely right. So I think, Dr. Vineet, are you there? Because I think we have come to the end of our discussions. If there are any questions from the audience which are not visible to me.
I think I request Shreyashi to just send all the questions to Dr. Aparna, so she can direct towards the panelist. There are few questions on the chat box.
Some we have answered.
Yeah,
I saw
some you have
of
already
the questions.
answered. Yeah.
We have received 2 questions and I've posted them already, but no other questions yet, ma'am.
I can't see which questions are we talking about. One Dr. Abhishek Sharma has asked about the VLCD that we discussed.
Okay, another question is there, ma'am, from Dr.
So,
Muthu Kumar.
That has also been answered that by Dr. Nagendra, that these patients have to be adequately hydrated.
Yes.
And there will be some group of patients where intraoperatively also we have, especially when there's prolonged colorectal surgery or there is a tremendous amount of third space loss and the patient was previously on SGLT, we must monitor, like we keep repeating ABG, so we must do a correction of and a goal-directed fluid therapy as well. Sir, good evening. I can see Dr. Jain. I can't hear you, but...
Dr. Aparna, I would like to ask one question to you.
Yeah.
The intragastric ballooning, they are doing it for reduction of the weight is concerned nowadays. So if the patient is coming to you with this balloon in place, what is your advice for anesthesia concerns in these kind of the patients? Balloon is in place.
Yeah, so yes, I can understand. So first, we don't have experience with intragastric balloons. So whatever I would say would be more theoretical because we haven't encountered patients with intragastric balloon. But intragastric balloons are usually removed by the gastroenterologist prior to being taken up for any surgery.
For any elective surgery.
For elective surgery, and they should be considered as full stomach. And I think the endoscopist, the gastroenterologist, should be on board. So what literature I have read is that they have to be on board and they have to be available in case any intraoperative manipulations are needed. So that are usually not done by the anesthesiologist, and we consider them to be full stomach.
Full stomach.
We sort of take. Yes, but this is all theoretical. I don't have any practical experience with intragastric balloon.
Okay, thank you.
Yes.
So, Vineet, should we conclude?
Yes, ma'am.
Okay, fine. So on behalf of Indian College of Anesthesia, I would like to thank Dr. Aparna, Dr. Nagender, Dr. Dinesh, Dr. Vandana, Dr. Anil Kumar, Dr. Anu Vijayant, and Dr. Sangeeta for a wonderful and excellent presentation on this topic. Because the literature and the practical modifications, literature is saying something, guidelines are there, but practical modifications are needed as per patient's need and during that time. Because many a time, that we have to just modify the guidelines or just deviate the guidelines, whatever we are supposed to do it, we are not doing it. So obesity is a real concern and care in these days. But if we do the proper monitoring, as Dr. Nagender said, Dr. Aparna said, then we can manage these cases well, and we can give the outcome to our patients. Medico-legal safety is a real concern. So all of us has to be really worried for that, and we should take proper steps to prevent all the medico-legal problems which can arise during such kind of the surgeries are concerned. So once again, thank you very much for you all.
Ma'am,
And
yeah, so thanks to all my co-panelists,
Yeah.
Dr. Dinesh, Dr. Nagendra, Vandana, Dr. Anu, and Dr.
Thank you,
Anil,
ma'am.
Dr. Sangeeta, and Dr. Vineet for especially helping us out. Dr. Manjula, thank you so much for sparing your time, and it has been a learning experience for me as well. So thanks to all of you.
Thank you, ma'am. Thank
Bye
you.
bye and good
See
night.
you next
Yeah.
time. Bye.
Thank you. Bye. Thank you, Vineet.
Thank you.
Good evening.
Bye.
Thank you.
Thank you.
Thank you so much, everyone, for giving us the opportunity to host the session. Thank you.
Thank you.
So with everyone's permission, I'm closing the session over here.